Hello and welcome to this week's video in pathology. We're going to talk about prostate cancer today, but we're going to do things a little bit differently by going through a clinical case. So what we have here is a 65-year-old African American man in good health that presents at your clinic after an abnormal PSA test. He reports normal voiding patterns and normal erectile function with no evidence of weight loss or bone pain and also no major medical problems. But he tells you that he has a strong family history of prostate cancer and ultimately he decides to have a biopsy. This is his biopsy, which is diagnostic of prostate adenocarcinoma with a Gleason score of 6. What I've just given you is a classic case of prostate cancer. Prostate cancer is the leading cancer in men and the second leading cause of cancer deaths in men. There are several risk factors, including age, family, diet, and race. Patients with one or more first-degree relatives with prostate cancer are at an increased risk of developing prostate cancer later on in life. Also, patients who are of an African American origin are at an increased risk of developing prostate cancer compared to men from other origins. Interestingly enough, Asians, particularly Japanese and Chinese Asian men, have the lowest risk of developing prostate cancer. Diet also seems to play a role in the pathogenesis of prostate cancer, so having diets that are high in meat and low in antioxidants will increase the risk of developing prostate cancer. A little bit on the etiology and the pathophysiology of prostate cancer. There are many different types of prostate cancer, but the most common type, the type that you have to know, is adenocarcinoma, which is present in more than 95% of the cases. They typically present in the posterior zone or the peripheral zone, although in some instances they may present in the transition zone or the center zone as well. Most patients will be asymptomatic. You will rarely encounter patients that present to you with bone pain or significant weight loss. The reason for this is because of the advent of PSA screening programs that are available all over the world now. Although what's interesting is that prior to PSA screening, many patients, or many male patients, actually presented with bone pain and signs of advanced prostate cancer. So, what is considered an abnormal PSA result? First of all, PSA is a glycoprotein that is produced by the epithelial cells within the prostate gland. Normally, they're in very low concentrations within the serum, about less than 4 nanograms per mil. Although in some cases, including cancer, PSA levels may become elevated. Some benign conditions that can result in PSA elevation include increase in age, benign prostate hyperplasia, any sort of inflammation to the prostate, such as prostatitis following urinary tract infections, or any kind of physical disruption such as trauma, digital rectal examination, or ejaculation can all result in increased PSA. So when you read these reports, or when you read these tests, always keep in mind that cancer is not the only cause of raised PSA levels. So as such, in most testing centers nowadays, they consider levels of 4 to 10 nanograms per mil as the gray zone, in which further tests have to be done in order to confirm the presence of cancer. Prostate cancer is diagnosed through ultrasound biopsy. What we expect to see in the histology is the absence of basal cells, which you can see right here, through high molecular weight cytokeratin staining. So this brown stuff is the basal cells, and you can see many of these glands in the middle lack basal cells, and this is actually prostate cancer right here. Other common features include prominent nucleoli, which you can see is right here, also enlarged nucleus, as well as crystalloids within the achnus. Staging is very important. It's a very good indicator, or prognostic indicator, but I'm not going to go through it in great detail. You can pause the video here if you'd like to read the slide, but instead I'm going to skip to Gleason grading, which is arguably the most important prognostic indicator in prostate cancer. It is based only on the architecture of the prostate cancer glands and not on the actual features of the cell. It is done by combining the two scores from the most dysplastic sample. Now, in my subsequent video, I will go through details on the criteria of the Gleason grading system, but in this video, I'm just gonna go through a quick overview and actually skip it. So look out for the video. You'll probably see it in the channel in the next couple days. In any case, going back to the case. In any case, let's go back to our initial case, and let's change things up a bit. So, assuming that this patient had a normal biopsy, what would you do?